Hello, dear colleagues. My name is Peeter Ross. I'm a radiologist. I'm a professor in e-health in TalTech, and also consulting some international banks. This is the content of this talk. First of all, I will give you some overview of Estonian state and government e-services, then go into the e-health platform, e-health services, and finally let's look what are the potential trends using nationwide health information system and data there. And I will put some emphasis also on the artificial intelligence. If we talk about e-health in Estonia, which actually is pretty advanced, so every resident in Estonia has its own health account, and every resident has online access, what is secured by the two-level authentication, has access to their own healthcare data. When we talk about this, we have also to discuss a bit the background of Estonian e-government system. As this summer school is virtually in Tallinn in Estonia, then I also have some compulsory geography points here. So we are located on the northeast Europe. Population is 1.3 million, and what is important to emphasize that every Estonian resident has a unique ID code. This is similar to Nordic countries and some other countries, but this is the link to any digital data of this particular person. Healthcare is organized similarly to other European countries, so we have a single public payer, compulsory health insurance tax, which is paid by employers. Health care costs are not high as we compare it to the share of GDP. We have only 6%, and maybe one of the reasons of this, let's say, efficient use of resources is also use of digital healthcare data. And our hospital system is publicly owned private hospitals, and GPs are private entrepreneurs. So it's a mix of NHS and insurance-based healthcare provision. As I mentioned, then when we talk about e-health services, then it's worth also to know and understand how widely e-services are used in Estonia in general. And here are just few facts. One of the funniest thing maybe you can appreciate is that almost half of the votes in any election are casted over the internet. So you can sit on the couch and vote, and this is secure and have proved to be very widely used. We have here in Estonia also NATO Cyber Defense Center, which gives us some confidence in data security and data protection issues. And we have a couple of unicorns also developed from Estonia. The most recent one is TransferWise, maybe, which is to transfer money with a much quicker and cheaper way compared to the bank transfers. Estonian nationwide health information system has not evolved in few days or even in a few years. The development has been several years. We started already in 2000. Then in 2004, when Estonia joined EU, then we got resources to invest into the e-health. So e-health system is partly financed by the EU funds. And after that, the development evolved quite quickly. And as you see on this figure, then the new services are implemented almost every year. But as I mentioned, it didn't start, as a whole block of sophisticated services, but step by step. In 90s and in 2000s, hospitals had their own electronic medical records, which were using their own standards. They didn't communicate to each other, so it was more like electronic typing machine rather than any data exchange. But gradually then health insurance started to accept only the bills what were submitted in electronic way. So this led to the need of healthcare providers to start to think about integration between their own institution and then some central database about security, to think about security, about the ICT infrastructure availability, about the network. Then the next step was that reimbursement of claims and prescription data was already compulsory to provide in electronic mode. And in 2008, when we implemented nationwide health information system, then gradually started integration between different healthcare organizations, GPs, hospitals, with health insurance, with health information system, and also with nationwide picture archiving and communication system. So it has been a long journey. I have been one of the designers and implementers of the system, so I pretty much knew what were the biggest obstacles and what were the factors what allowed us to develop this in the way as we did. And I will share this with you now during next maybe 15 minutes. Now we have listed maybe 8 main drivers what are important in development of large-scale health information systems. Would it be regional or would it be nationwide? It depends, of course, on the size of the country. But anyway, we have to take into consideration at least these factors what are listed here. So first, computerization and computer skills in grassroots level. So there is no sense to come with new services if you have very low computer literacy among the healthcare professionals, and also if you miss computers. So this is the first prerequisite. Funny thing is that it's not a funny thing, but it's very important thing that we have to put in place financing before we can make long-standing strategies. And what is funny thing is that if the financing comes not from the Ministry of Health or not from the Ministry of Social Affairs, but comes from other sources, then you might be much more successful when it comes from the Ministry of Health, because Ministry of Health likes to allocate money to only to medical services, rather than think what IT could bring to make these services more efficient and available and increase quality. And this is obvious that physicians like we have trained as a medical professionals, not as IT professionals, and therefore we would like to get better machines for the diagnosis or better knives for surgery, rather than think a change of the everyday workflow and patient pathways, what are allowed by the digital tools. So financing better if it comes outside from the healthcare budget. Clear governance is important. Health IT also could be implemented only with top-down approach, because computers don't like democracy. They want to have clear codes. Then legal clarity important. I will address this item on one of my next slides. Estonia has used mature e-government ecosystem also, so we didn't build e-health infrastructure separately. We are using identification, also data exchange security standards similar to other e-government services, so there was no need to invest additionally for the health. Agreement about access rights, who has right to see what documents and data. This is important. And last but not least, standardization of medical data, and also standardization of data exchange. This slide is about e-health architecture. On the upper row you see different databases, and the idea of our e-health system is that we try to keep data where it is generated. So there is no duplication of residence data. For instance, the single source of truth is population registry. Similarly, healthcare professionals and providers registries, others are in own server, and they are accessible through secure data exchange layer. We call this X-Road, which is a platform securely exchange data between users and different databases. And then in the lower row you see the services what are provided by the e-health system. We have a nationwide health information system with several services. We have prescription center where all electronic prescriptions are stored, and nationwide packs. And patient or citizen have secure access to this data through patient portal. So using your ID card or mobile ID, you can see exactly the same data that healthcare professionals see about you. So it's very transparent. And this kind of architecture gives us a possibility to apply different value-added services. Here, this yellow database is a drug-drug interaction database, and once in Estonia all prescriptions are in electronic mode and accessible from the one database. So then it doesn't matter where the patient goes to see a doctor. If there is interaction between the already prescribed drug and newly prescribed drug, then you will get actually this physician who prescribe gets alert about the potential interaction and advice to maybe choose another medication. The blue database is, or service is about driving license health certificate application, and you can do this in Estonia also online. You log into the road authority website. You give your permission to retrieve your health status from the medical database. If it's enough good to drive, you get a right away permission from the GP, and if the health condition doesn't allow to drive, then the information what comes there that we don't know, we don't give you permission to drive, so it doesn't disclose any personal information, just says that this person has no right to drive because of the health reasons. More specifically, here on this slide are listed what kind of documents are available in e-health system, what services like e-prescription, e-referral, e-ambulance. We discussed already about the drug-drug interaction service, countrywide digital images, and so on, and also cross-sectoral services like this health declaration for driver license exchange, or working incapacity assertion, which is if you are sick, then you don't need to go to see a doctor to close your sick leave, but this is passed electronically. An example about a patient portal. These are screenshots you can use for the login, either mobile ID or ID card. Both are working. You enter your PIN codes, and then these are the opportunities what the citizen can see in this portal. On the blue box there are medical data, but you can also view the price what health insurance has paid about your treatment. You can make your intentions of will, either donate your organs or after your death, I mean, or allow blood transfusion, and so on. So it's a quite wide set of options what a person can do in his or her personal health account. Also book appointment all over Estonia. This illustrates the medical information, so you can look case by case, and you can also close data by case from either physician or your trustee. This is how the report of one encounter looks like. What is very important, what increases trustability and also transparency, is that every citizen can see logs. So if I, as a medical doctor, look at the at my patient data, then the patient can see when and what I have looked. So this is my log, and you see I personally have been looking my data quite often, because I often would like to show in the lectures how it looks like. Legal environment is very important. Also, if you think about development of some health service or some social care service, you still have to think what legal consequences with your app or a tool could be followed. And Estonia, in terms of health information system, has passed separate chapter in the Health Service Organization Act that regulates the development and maintenance of the health information system, and puts up main rules. It's also compulsory for the healthcare providers to share patient data through National Health Information System. It doesn't matter are you a small provider, big provider, private or public. Everyone to get a license have to also be integrated with. We are using attending doctor concept, which means that if a doctor has a treatment relation or nurse has a treatment relation with a patient, then he or she has a right to look at the patient data. Patient can close the data, which means has a right to opt out. But then if he or she wants, then they can again open the data. We have also ethical committee, and as I mentioned, then citizen can access their own data, declare intentions and preferences, and also monitor logs. To sum up this e-health system, major and specific features maybe for Estonia, because every country has at least some specialties if you compare to others, so there is no possibility to copy Estonian model to any other country. You have to understand also organization and politics in the background. But our specifics were that we were using the data exchange layer, what has been provided by the state, also for other e-services. Opt-out policy, I will advocate this and we can discuss later on about this. If you have questions, why opt-out policy is preferable from the opt-in. Very strict and very clear and very transparent use of standards. We publish standards what are used for data collection, data exchange in the website of the ministry. So all healthcare IT companies could have access maybe half a year before the change will be made and can prepare for the new standard releases. And reuse of national infrastructure. Some facts about the results. This is one of my favorite graphs. You see the green line is about the number of documents or data elements like lab test results or patient summaries or reports, consultations, which are shared through the central database. And the red one shows the use of the healthcare professionals of e-health system. And you see in the beginning the uptake was quite low. Not many physicians were using it. But today we have hundreds of thousands queries a week. So it's natural tool for the healthcare providers in the diagnosis and treatment. But what is the most important and interesting thing is that the blue line. And blue line is about citizen access to their health data through patient portal. And this is almost as frequent as with healthcare professionals. So you see from the designer point of view of this kind of system, this is really rewarding, because you see that the use of this kind of platform is not only for some small groups, but it's both for the healthcare professionals and also for the citizen. We of course don't know yet what are the consequences, what are the real final benefits, because it would the comparison of this kind of large-scale socio-technical implementation takes time. In Estonia, we have all prescriptions in electronic mode. So paper are used only very occasionally, and if even used, then it's digitalized in the pharmacy. So we have full database of prescribed drugs. This is another graph about health data use by patients. And on the red bars are presenting ladies and blue gentlemen. And you see at the beginning, ladies were the most main users. And it's important to also to appreciate this fact, because these are the groups who want to use e-services: younger people and ladies with it, when they plan, for instance, pregnancy or childbearing age. But later on, you see also men have been gained and are using quite a lot the patient portal and data from there. Now let's jump to the artificial intelligence, AI. This is a very hot topic today in healthcare, and I have to disappoint you. I don't see as quick development here as been anticipated. I have worked as radiologist more than 20 years, maybe 25 years, and from the first day I have been told that, you know, computer will replace you next year, maybe after 2 years. Now I have worked 25 years, and each year I have more work than the previous one. So computer has brought me more work rather than removed me from the healthcare provision market. And let's see what has why the situation is like it is, and what are the opportunities there. We discussed during at my previous lecture about data quality, importance of data quality, and I have to emphasize this again, that we need structured and standardized data as much as possible to give opportunity for computer for helping to help us to apply algorithms and so on. If and this applies to any computer field, that if the garbage goes in, then also garbage comes out. So we have to put a lot of emphasis on the data quality. So what has happened during the last 20 years? Yeah, we have some advancements as listed here: digital libraries, imaging has changed a lot, some medical records, also some digital decision support systems. But the work of the healthcare professional has changed quite a few, and so we haven't seen as much benefit from the digitalization in the healthcare industry as we have seen in banking or other service industry. So these were the benefits. Where are we today? And if I don't dig into the AI methods, I generalize the findings. So where we are today, artificial intelligence is still trained by the human being or by human activities. Even I, as as radiologists, have to assign findings on the image for the computer. But this is my work time, so this is very, very expensive. Still, AI is capable to learn quite linear tasks, and this is shown by CAD in mammography. CAD stands for computer-aided detection, and mammography is the imaging of breast to find cancer. And this is very homogeneous image, but still we have been able during last 20-25 years to computerize it fully. There are several reasons. One of the reasons is that human health data is 5-dimensional. Now you have these 3 spatial dimensions, and then you have movement, which is time, and then you have a longer time period. So you have to keep in mind all these changes, which is hard to explain to the computer. So it seems that medicine evolves quicker than we could teach algorithms. What can we do to help? Because this is quoted by quite many prominent people and or scientists, and I also agree that the AI will help healthcare professionals and people to improve their health outcomes and so on. But we can't. We don't see opportunity that computer takes everything over. So data structuring is important, and not only data, also some functions like referral letters, reports, and start to develop simple algorithms. Today, if I report, let's say, left hand X-ray, and write on the electronic medical record report right hand, then even this small discrepancy is not highlighted by the computer. So this is so easy. But these kind of tools and applications, what have been also listed on this slide, these are the steps how we learn how we can use computers. And then after that, we can open the health information system potentially to third-party services, either to use more decision support system for data entering or data analysis, creation of virtual registries, automatic analysis of care quality and performance, and also develop new health, medical, or social care services, integrating different databases or integrating even cross-sectional databases. And if you go back now to the architecture, what we have for the state-owned health information system, then we have to widen it a bit. But what we need to do, we have to open the database also for the health apps, that also person can add their own data to the their health database and do it reliable mode. We have to make agreements between the industry and the social sector that that as much open data as possible could be used. And we have also to make links with financing institutions, because obviously state can't guarantee every service, but sometimes people need to pay for that. And this will also allow then in the future to use as more genome data if you have clear consent engine in place and so on. Right, so to sum up, we have seen during this 10-15 years paradigm change of healthcare professionals, but also for with people. So it's not anymore that a physician is the owner of the data, but the data belongs to the patient, and it's shared throughout the healthcare community or with peer patients if patient wants to do so. So the data ownership change is there clearly. The use of data is changing. It's not only primary use. Now we can apply digital decision support systems or drug-drug interaction databases. Workflows are changing. And from the data security point of view, as in Estonia, we are using kind of blockchain concept to track the activities in the healthcare hash chain. Then it has shown to be very reliable. So there are no any data breaches from the health information system during all the existing period. So it has been a quite interesting journey to develop this system and to also nowadays to use it, though we see that a lot of potential is not used yet, and we need to open the data to industry more and more to benefit the digitalization of data.